Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, please feel free to type in your questions at any time. Please note that all questions will be saved until the end of the webinar, and we have allotted time to answer as many questions as possible. Today's webinar, Advanced Technologies in Pituitary Surgery, the Role of VR, AR, and AI in Achieving Better Outcomes, is presented by Dr. Robert Lewis, Director of the Skull Base and Pituitary Tumor Program at Hoag Neurosciences Institute in Orange County, California. Please hold as there will be a brief delay while we change presenters.
Welcome everybody, and thank you for joining us this afternoon. It's my pleasure to be here and to be discussing some of the recent advances we've made in technologies which can make pituitary surgery safer and more effective. So just to kind of dive right into it, we're going to start with an overview of the problems that some of these technologies address, and then kind of back out from there, do a little bit of history, and then move forward as to how we've arrived and how we deploy some of these things in the operating room to make surgery safer for our patients. So we're going to go through 5 problems in the course of this talk. And the first one is that traditional systems, such as DICOM-based imaging, force surgeons to visualize images through a radiologist's point of view. We're going to talk about why that is, essentially that the MRI systems give surgeons the images in these kind of cross sections and in black and white, and they're reversed and upside down. And so it forces the surgeons to learn to look at it from the radiologist's point of view rather than to be able to study the images from the surgeon's point of view, which is the way we see it in the operating room. Number 2, there was or is no way to practice an operation on a specific patient prior to surgery. We have these kind of anatomical skull-based slabs where we go and we can practice an approach on a cadaver, but that's not a specific patient. They don't have the pathology that this patient you're going to treat has. So prior to the advancements in recent technology, there was no way to practice an operation on an individual patient. Number 3, patients themselves, including maybe many of you, do not understand DICOM images. These kind of black and white images that look like a Rorschach blot. They really don't make sense to people unless they're specifically trained to interpret medical images, which of course most patients are not. Number 4, the traditional way that we analyze tissue in surgery is a frozen specimen, but this is slow. It's a time-consuming process. It takes about a half an hour to get a result, and often they are inaccurate, particularly with pituitary surgery in differentiating between adenoma and normal glands. So we're going to talk about how we're solving that problem. And then finally, traditional navigation systems require the surgeon to divert their attention away from the operative field in order to gain the information as to where exactly they are, and then return to the operative field kind of once they've gotten orientation. And this leads to what's called context switching, which decreases the operative flow, and again can result in suboptimal surgical workflow and outcomes. So just a bit of a historical perspective. Neurosurgery is a relatively young field. It was actually 1885, which is the first reported case of surgery for a cerebral tumor. In fact, this was before any imaging was available at all. This case, the patient had weakness of the left arm and hand, and these physicians, the neurologist and the surgeon at the time, were able to recognize that that meant he had a tumor on the right side of the brain, and that they were able to successfully, with a drill and knock a couple of holes in the skull, localize the tumor and resect it without any navigation, without any anesthesia, or without any antiseptic technique or antibiotics. So the patient ultimately died from an infection, again, because there was no antibiotics available. But this is the first time in human history that it was known that the surgeon was able to successfully intervene on the human brain. Since that time, there have been numerous advances in techniques and technology which have enabled us to do these surgeries more safely and progressively less and less invasively. For example, in 1973, the MRI, the first MRI was produced, which enabled us to generate these type images on the right, which gives the ability to differentiate different tissue types, to identify blood vessels, to identify the ventricles and the brainstem, as well as tumors, infections, blood clots, and those kind of things. Fast forward until 1987, this is when intraoperative navigation was introduced. So prior to that time, the surgeons had to kind of look and feel their way through an operation based on their known understanding of anatomy, and in particular this patient's anatomy. With the advent of intraoperative navigation, surgeons for the first time had the ability to have a reference frame as to where they were in 3D space during the operation. And this is the technology is based on sextant arm technology, which is what sailors used in the 16 and 1700s in order to navigate by the stars. So this was a significant step forward in the development or the advancement of neurosurgery. However, one important thing is that it took about 15 years for it to become commonplace, meaning most surgeons were using navigation, because in part, neurosurgeons have big egos. We tend to think pretty highly of ourselves, and we think, yeah, you know what, I don't need that. I just kind of put my hand on the top of the skull, and I know that the right place is next to my first knuckle or my second thumb, finger. In reality, when we put our egos aside and recognize that these technologies, as with many aspects of our life, can make surgery safer, can make it more efficient, can make us less likely to do harm, then the navigation became an obvious choice and eventually became standard of care. One of the things I'm involved in is the development and advancements of these techniques and technology, particularly with regards to skull-based surgery, minimally invasive surgery, and the access to the pituitary and the surrounding regions. So as we mentioned with things like navigation, there have been numerous other technological advances. This is my mentor, Dr. Dan Kelly, on the left, who many of you may know, one of the world's top pituitary surgeons, and I was fortunate to train under him. And many of the things that I learned from Dan, Dr. Kelly, I'll be talking through today, and of course carrying that further, as students often do. One of the things that's allowed us to do these surgeries less invasively is the development of refined instrumentation. So when you're working through a small hole, for example, the nostril, the instruments you use have to be specifically tailored to work up that small portal without getting in each other's way, or what's called sword fighting, where the instruments are bumping into each other. Another particularly important tool has been the use of a Doppler vessel probe, which allows us to listen for the position of important arteries, in the case of the pituitary surgery, the carotid arteries, so that even if we can't see them, we're able to listen with the probe and determine where they are so we can avoid injuring them. And of course, one of the most important advances for pituitary surgery has been high definition endoscopy. Over the last 10 years, the movement from 720 to 1080p to 4K has allowed us increased ability to visualize the critical structures. For example, this image right here of the optic chiasm, these vessels on the surface of the chiasm are about 1/10 of a millimeter. So tiny, tiny vessels, but we're able to visualize them because of the high resolution endoscopy. Now, most places in the body, a vessel of that size wouldn't make much difference. However, in the chiasm in this location, even the tiny vessels which supply the optic chiasm can result in visual loss because the fibers are so densely accumulated here. So we want to be able to visualize and therefore protect as many of these structures as possible. So this, again, the evolution of camera technology with 480p in the left up to 4K now, and of course, I would imagine the next couple of years will be at 8K, which is pretty much as far as we need to go because the resolution of the human eye is only 8K. So when we get to that point, you won't be able to tell the difference between what you're seeing on a screen and what you're seeing in the real world around you. So, this is just one of those questions. As the resolution gets better and better, you want your surgeon to be able to see in higher and higher resolution to visualize and preserve those structures. This is just another example of this ultra high definition endoscopy, which we use on the optic chiasm, as well as in the ventricles to be able to see down into the foramen of Monroe. However, as of 2019, there are still significant problems in neurosurgery, particularly with regards to our planning and preparation for surgery, as well as navigation during surgery. Since the advent of navigation in 1987, there have been what I would say relatively few advances in the way that we use it, both to plan for surgery as well as operationally during the procedure. It's kind of been a slow march, and so it has left us with several problems of that many operations are still relatively imprecise. And so that leads us back to problem statement number one again, and that is that traditional systems force surgeons to visualize images through a radiologist's point of view. Because it was the radiologist that created the MRI machine, they chose to give us these kind of cross sections of images in black and white, which are given to us in these perpendicular planes, the sagittal plane, the axial plane. So we have to scroll through an image like this and kind of try to, like a flip book, flipping through a story, try to reconstruct this scroll or these slices in our mind in order to create a three-dimensional picture. While we think we're pretty good at this, again, we big ego neurosurgeons think we're pretty good, we're actually relatively bad at it. In other words, if you were to test someone and ask them, after scrolling through this, I would like you to draw in 3D space the structure and shape of this tumor and where the vessels are all located around it, you'd have a pretty poor result because we're just not great at interpolating data and reconstructing it in a three-dimensional model in our mind. We're much better at seeing a 3D model and then remembering it than we are at recreating the data from these 2D images. So again, these are the radiologist's point of view, which we've been forced to use because this is all we had. So for, many of you may know, when we look at this, the left side of the brain is actually on the right side of the screen, which doesn't make sense for us if we're surgeons, because that's not the way we're going to see it at surgery. So it's an extra step. It increases what's called cognitive load, and it decreases the intuitive nature of what we'd like to have be relatively, simple workflow through the operation. By comparison, we now have technologies which enable us to take those same images, so this is the same MRI from the same patient, and reconstruct it in 3D in order to be able to allow the surgeon to visualize all of the relevant structures, not in two-dimensional slices that we have to reconstruct, but in a single image, including the surface veins, including the tumor, including the cortex itself, the motor fibers, which are kind of splayed here on either side of it, and the important structures, whichever we choose to see, they can all be visualized in a single view, which can then be positioned into the surgical perspective so that I'm studying the images in the same position they will be during surgery. Now, the advantage of that is actually very intrinsically obvious. That I don't have to reposition it in my mind and flip it upside down and remember where everything is. It's displayed for me as I will see it at surgery. So I can study it, not in an ideal patient or in a kind of textbook where the anatomy is not always perfect, in this specific patient, so I can know exactly where the critical structures are. So again, the ability to see these multi-dimensional images, but with all of the critical information displayed in one point of view, it enhances the surgeon's ability to study these images and prepare for surgery. So when we add on top of it these virtual reality, these 360 images, and then we combine that with artificial intelligence, we can start to see the ability, not only do I want to see the images this way. First, we started off doing it, we had to manually paint in many of the structures by hand. But fortunately now with machine learning and AI algorithms, we're able to train the algorithms to identify these structures on their own. So this is an example of a machine learning algorithm which is able to identify the optic nerves. So here you can see we're scrolling through the three-dimensional model, and so far the optic nerves do not appear in this image. Optic nerves are particularly relevant during pituitary surgery. As we know, there are optic nerves and chiasm are often displaced. So you can see here on the left the progress bar, which is essentially the progress of the machine learning or artificial intelligence algorithm processing out or identifying the optic nerves, and very soon they will appear in this image completely, picked up by the computer, so with no human effort at all. And then all I have to do is go back and verify the accuracy of these. So once the computer generates the images, it takes a lot of the manual work out of this, and again, it can help us to predict where these structures are going to be during surgery. So there it is, in less than a minute, the AI algorithm was able to identify the position of the optic nerves and transpose that or add that into my three-dimensional model so I can see exactly where they'll be during the surgery in order to be able to protect them. And as I do here, I double check, I verify that indeed the computer did a perfect job of identifying the optic nerves and tracking their course back through the chiasm and eventually back into the optic tracts. So that's just one example of how artificial intelligence can be used in combination with these 360 models in order to help us better visualize and plan for surgery. So, problem number 2, there is no way to practice an operation on a specific patient prior to surgery. Before virtual reality, my preparation for surgery was literally thinking through an operation, scrolling through the images and thinking, okay, I'm going to do this, and then I'm going to do this, and kind of trying to visualize it or fly through it in my mind. Well, again, as we said before, that's a relatively imprecise process. And this is one area where there's significant difference between physicians and surgeons and other high-level performers such as elite athletes. Dr. Chris Ahmad is an orthopedic surgeon for the New York Yankees. And he wrote a book called Skill, where he compares the skill set and preparation of elite athletes to those of elite surgeons. And there are many similarities where he talks about, the 10,000 hours and continued practice and honing your skills. But the one major difference is that professional athletes like Michael Jordan, when he began playing for the Bulls, even after he won 5 championships, still practiced 5 or 6 days a week. By comparison, surgeons, as we get into practice medicine on our patients. There is no ability to practice before an operation. We have no systems in place in order to allow us to simulate and practice on a specific patient. And as we know, practice, while it may not make perfect, practice makes better. So there is a need to practice. And so this is a problem which has recently been solved by virtual reality. So there's numerous publications supporting the use of virtual reality for surgical simulation. This one publication, which went all the way back to 2008, showed that 23% of the time using virtual reality for simulation led to a change in the surgical plan, while almost 90% of the time it led to a good or very good improvement in the craniotomy planning. In addition, most surgeons reported that it gave them what's called a deja vu feeling, meaning once they've done the VR simulation, they feel like they've already been there, and therefore it increases their confidence during the surgery. This is an example of how this has been put into practice. This is a patient of mine, which based on the preoperative imaging, the patient had a tumor near their right optic nerve. Based on my DICOM images, the 2-dimensional black and white images, I was planning to do an approach through the right eyebrow, so to remove this tumor near the right optic nerve. But when I did the simulation prior to surgery, I realized that this approach was not going to work because I couldn't see this little tongue of tumor in green right down behind the supraorbital fissure. So what I realized in the simulation was my plan was incorrect. Rather than making that mistake in a patient, I made it in virtual reality and was able to change the plan. So this is plan B, now simulating in virtual reality. And from this approach, I get a much better direct approach to the tumor. I was able to simulate it, change the plan, counsel the patient about it, and rather than making that mistake in the patient, I did it in VR, changed plans, and was able to remove the tumor completely and restore his vision. So this is just one example of where using virtual reality for a preoperative simulation led to a change in the plan, which ultimately resulted in a better outcome for the patient. This is the point of these technologies. Anything we can do, anything you can put in my hands in order to make surgery safer, I want that tool because it's the patient's lives that matter most. And these technologies are empowering us to do things that were never before possible. What this gets at, this idea of simulation, is it allows the surgeon to predict line of sight. There have been numerous anatomical studies on this, kind of trying to figure out which approach is best. And there's these kind of like several what I call cookie cutter approaches, where there's standard template craniotomies. But using VR, rather than creating a standard template, you can create a specific precision opening or precision craniotomy that's going to be ideal for this particular patient, not one that's kind of widely applicable to numerous different patients. This is the advantage that simulation and virtual reality affords us. And again, it's been studied time and time again with almost identical results. Nearly a quarter of the time, using virtual reality to simulate the operation leads to a change in the surgical plan. In other words, if you didn't do it, almost a quarter of the time you may be doing a suboptimal or incorrect approach. That problem statement number 3, and this may ring true to many of you who may be patients or may have experienced this in your own lives. Patients do not understand DICOM imaging. If you look at these two images right here, you know, which image is easier to understand? They're representing the same picture. On the left, you see a traditional coronal slice DICOM image with this pituitary adenoma displacing the optic chiasm up. And to most people, like I said, this looks like a Rorschach blot. Is it a butterfly, or is it a bat, or is it, you know, two witches kissing? Most patients have no idea, you know, what they're looking at when they look at this. The image on the right, the 360 model, it's relatively intuitively obvious what it is. You can see where the blood vessels are. You can see where the tumor in green is. Even my 8-year-old daughter looks at it and understands relatively what's going on. So let's just take an example of this to go a little bit deeper into this concept. If you look at these two again, side by side, same patient, you know, where the tumor is kind of, you know, this light gray area within this darker gray or brighter white area, and this little gray band is the optic chiasm. By comparison, the image on the right, same patient, much more intuitive to understand for the patients. So while it's a scary moment for patients to undergo these procedures, what we do by doing these fly-throughs is prepare them by arming them with the knowledge to better understand it.
For you to understand your condition. Let's take first a precision 360 patient-specific model.
So this is the model of the patient's own anatomy, showing where the pituitary gland is, including where the posterior gland is, in order to know where it is to prevent diabetes insipidus. Here's the tumor. Here's its close approximation to the optic chiasm above, and the right carotid artery. Again, this is much more intuitively obvious, and therefore helps to put the patient at ease as compared to these DICOM images. And this is one thing we've studied extensively in my institution. So by using virtual reality, we studied the impact of patients that went through traditional consultations, meaning they're looking at the DICOM images and maybe they have some illustrations, versus using 360 virtual reality consultation. And what we found is pretty remarkable. This was a study of over 250 patients over the course of 3 years. And what we found was, prior to the virtual reality consultation, more than a third of patients were leaving our health system and going up to other regional hospitals. This is because maybe they didn't feel like it was the best place for them, or maybe they had a lower level of understanding, as is evidenced by the data here. So the black lines here are before the VR consultation. And once patients went through a VR consultation, almost 90% of them had a level of understanding as a 9 or 10 out of 10, which is a significant improvement. What that led to is a significant number of patients staying here and having their care here at home. And the reason for this is because they felt more comfortable. They felt empowered. My job, I tell patients, my job in the healthcare team is I'm the CMO, meaning my job is to give the medical information to the patient, and the COO, in other words, execute the plan. The patient is the CEO or chief executive officer of their own healthcare team. But they can only do that if we empower them with the information. So my job is to try to accelerate the patient's learning curve so that they have a very high level of understanding of their condition, of the risks of the surgery. And so what we find after they've gone through this VR experience is that they really have this kind of, they grab onto it and they have a complete level of understanding of what the risks of the surgery are. And it empowers them to kind of go into the surgery, and while there's still some fear, at least there isn't the fear of the unknown, because they have a much better understanding of what to expect from the surgery and the postoperative period. So what this does essentially is helping patients feel more prepared for surgery. Problem statement number 4. Frozen sections, which is the typical way we've always looked at intraoperative pathology, are too slow and are often not accurate for intraoperative diagnoses. It takes about 30 minutes for them to take the tissue from the operating room, carry it downstairs to the lab, freeze the tissue, stain the tissue, look at it under a microscope, and prepare it. In addition, because of artifacts that occur, like process artifacts with this process, it is often difficult to distinguish pituitary adenoma from normal pituitary gland. This is particularly relevant with small pituitary adenomas. So we know that pituitary adenomas are slow growing. They are very, very common, up to 15% of the population when you look at autopsy studies. Oftentimes they can secrete extra hormones and things like Cushing's disease, where the biochemical effects of the tumor are devastating and can be widespread. However, one of the challenging things in Cushing's disease is that up to 40% or so are not detectable in MRI. The tumors are so small, meaning 2 or 3 millimeters, that they do not show up on the MRI. And therefore, if the diagnosis of Cushing's is confirmed by biochemical testing, the surgery to locate the tumor is often exploratory, meaning this very fine sifting through the gland with a very fine knife in order to try to locate the tumor. One of the most important aspects of that is being able to visually identify the tumor. But another is that if I think I found the tumor and I want to identify, is this the tumor or not, or is this normal gland, I need a way to rapidly distinguish tumor from normal gland. Again, I'm not going to sit there for a half an hour each time I take a little piece and wait for the return of the frozen specimen, especially when I know the results are relatively inaccurate. Fortunately, now we have a much more advanced technology, which is something called simulated Raman histology. What this is it takes the tissue and we put it on a slide in the operating room, and it uses lasers to diffract through water and then through the tissue and give a molecular fingerprint of the tissue type, which is then rendered back on the screen to appear like a typical histology slide. So what this does is it gives us, in 2 or 3 minutes, it gives us the same images that normally take 4 to 5 days to produce. So these are examples of simulated Raman histology from pituitary. These are normal pituitary gland here. You can see that the cells are kind of clustered together in the functional groups, which are the things that secrete the hormones, as compared to pituitary adenoma, where it's lost those kind of functional acini or packets, and there's more of these kind of sheets of cells with a higher number of nuclei or a higher number of cells throughout. Again, another example over here to the right, where the pituitary cells of the normal pituitary are kind of clustered together in these packets, with the reticulin or the architecture, the connective tissue kind of wired throughout, holding things together. And by comparison, pituitary adenoma, where a lot of this architecture has been lost. So this image is generated in, again, 2 or 3 minutes in the operating room. And to further support that, there's artificial intelligence, which helps us to rapidly make the diagnosis. So attached to the same system is an artificial intelligence network, which was trained on more than 2.5 million images of brain tumors. And this publication was from Nature, one of the most prominent biomedical journals out there. And the artificial intelligence-based diagnosis was found to be equivalent to experienced neuropathologist interpretation. In fact, not statistically significant, but slightly superior to the neuropathologist interpretation of the same slides. What that tells us is that between these combinations of advanced histological techniques, such as scatter histology, simulated histology, and artificial intelligence, we can get a much more rapid diagnosis, and therefore it can help us with decision support in the operating room to decide, is this tumor and I should keep resecting it, or is this normal gland and I should keep looking to try to find that small tumor? Again, particularly relevant in the case of things like Cushing's disease, where finding that tiny tumor is so critical to the patient outcome. Because if we don't find it and we're not able to get the patient into remission, we know that the morbidity of Cushing's disease is high. In fact, the mortality is significantly high. And sometimes, if it's unable to be cured, oftentimes will lead to death 20 or 30 years earlier than would be the natural lifespan. Finally, problem statement number 5. Traditional navigation requires the surgeon to divert their attention away from the operative field. So this is a navigation system, one of the most advanced ones there, the Stealth Station 8, which gives us these images and tells us where we are in 3D space on these, again, two-dimensional slices of images, axial, coronal, and sagittal. I use the analogy that this is the same as when we used to have to pull over our cars and look at a map in order to tell where we're going. It used to be, if you were lost, you'd have to stop the car, pull over to the side of the road, look at the map, find out where you were on the map, figure out where you're trying to go, and then plot a course to get there before you went back to driving. This is what we have to do using traditional navigation now. If I want to find out where I am in the brain, I have to put the probe in, tap the pedal, stop the operation, look over at the screen, at the navigation screen, look at where I am in these cross-sectional planes. Okay, this is where I am, this is where I am, this is where I am. Try to reconstruct those images and create a plan or figure out where I'm going from there, and then turn my attention back to the surgical field. This, again, it creates multiple challenges, one of which is disrupting the operative flow, one of which is increasing cognitive load on the surgeon. It just, every time you have to stop doing what you're doing and focus your attention on something else, it decreases the efficiency, it decreases the flow, and it interrupts your ability to get the job done in the safest and most efficient manner. Fortunately, nowadays, augmented reality has come into play, which allows the surgeon to see what they cannot see. So the image on the left is an unaided image showing a tumor above the pituitary gland, encasing the carotid artery and left optic nerve. We can see the image through the microscope. It's really difficult to see. In fact, it just looks like kind of like a big blob. When I turn on the augmented reality image, I'm able to see the position of the tumor. I'm able to see the position of the ICA, the internal carotid artery, sweeping off towards the left. I'm able to see the position of the optic nerve, kind of diving in. Now, when I look over at the augmented reality and then I look carefully over here to the right, I can kind of see this band of the optic nerve. But boy, it's helpful to have this additional image to show me exactly where that structure is so I can avoid injuring it during the operation. Because the entirety of this operation is trying to get this green tumor out without injuring optic nerve and carotid artery. So the ability to see what we cannot see is what augmented reality affords us. And it's in a heads-up display. It's right there in our stream of view. So I can just continue operating. I tap the foot pedal, the AR comes on, I'm able to visualize what I need to, I tap it off, and I keep going with the operation. So just to summarize, the advantages of augmented reality allow the surgeon to maintain focus on the operative field. They improve surgical workflow. They prevent the context switching, which decreases the cognitive load on the surgeon. They enhance spatial awareness, so allowing us to know what other structures are in the area which might be subject to risk. And they even allow us to see what we cannot see. So they give us that kind of Superman vision to be able to see through and around and into structures so that we can best be able to complete the operation safely. This is another example of augmented reality. So this is the standard view, unaided view of the cella with before the dura was opened. So endoscopic view here, and then here once we open the cella. Of course, the views on the right are with augmented reality showing me where the optic nerves are, where the anterior cerebral arteries are, the carotid arteries, and of course the tumor in green. Again, lining up the bottom of the tumor, even before I can see it with the ring and start to dissect it, I know exactly where it is and I can follow the contour of the tumor, even again if it's outside of my field of view. So augmented reality equals Superman vision. And actually this was something, that a clip that ran on CNN recently based on this exact technology, and it said, you know, augmented reality gives surgeons superpowers. And although I can't exactly claim superpowers, I do love the idea of this technology really starting to become recognized for the value that it provides, because afterwards, once we've removed the tumor and we can see the shell of where it was, including the remnant of pituitary gland here, and it's connected to the stalk, again, this three-dimensional spatial awareness that it gives us, there's really no other way to replicate that. Just to kind of, you know, show this point a little further, this is a surgery, a live video of a surgery. On the left is the endoscopic view, and on the right is the augmented reality view. You can see the target where the crosshairs is. On the left, you can see this kind of blood in the field. I can't really see where the tumor is. The optic nerves are in green. I can't see where they are. But because of the augmented reality view on the right, I'm able to know exactly where they are. Therefore, I can place my incisions in the right places. without risking injuring carotid arteries or optic nerves. And then as I peel the dura up, I can start to visualize the tumor, which I was able to see before in purple, even before I opened the dura. And now as I dissect around the borders of the tumor, I know exactly how far I can go safely because I know from the AR where the borders of the tumor are. So this gives me this additional degree of safety as I dissect this tumor down and out and pull it away from the normal pituitary gland, that I'll be removing only the tumor and not damaging the important structures. As I get most of this tumor out, you can see there's kind of a bubble of it that extends up, and this is this kind of cystic portion which extends up. You can see that matched up over here on the left side of the screen. What I can't see, though, is the optic nerves. The optic nerves are in green. Fortunately, because of the augmented reality, I know exactly where they are. So even though I can't see the optic nerves, I can safely introduce my curette kind of around the corner and be able to scoop out a couple of small remaining pieces of tumor in order to get a complete resection. Again, this is seeing what I cannot see, allowing me to see around corners and behind things in order to get the best resection possible, which ultimately results in a better outcome for the patient. So what are the results of this? So this is a kind of a summary of our 3 years of using this technology, resulting in higher rates of visual improvement, higher rates of complete total tumor removal as compared to the literature, approximately same rates of postoperative CSF leak, and lower rates of readmission. And this particular last one is due to, I believe it's due to lower rates of diabetes insipidus, because again, that three-dimensional awareness and the mapping of where the posterior pituitary is gives us a spatial awareness during surgery to be able to not just kind of guess where it is until we see it. We don't want to happen upon it. We want to know exactly where it is so we can avoid injuring it. There have been other studies, other centers such as Mount Sinai University in New York, who have studied the same technology. This is a series of 134 endoscopic skull-based cases with, again, significantly improved outcomes in lowering the risk of complications. This is another study, combined study with Hoag, my institution, as well as University Case Western Reserve, Houston Methodist, and the George Washington Hospital, demonstrating the accuracy and the enhancements that come along with using augmented reality for skull-based surgery. So in summary, again, advanced visualization technologies in neurosurgery have come a long way. They are now becoming increasingly common across the major institutions in the United States. They give the surgeons the advantage of allowing the surgeon to visualize images from a surgeon's perspective rather than a radiologist's. They enable preoperative rehearsal or simulation for the surgeon to be able to experience this specific case with this specific patient's anatomy prior to ever stepping foot in the operating room. They enhance the patient's understanding of their own condition and the surgical plan, and therefore give them an increased degree of comfort going into the operation. Simulated Raman histology, again, is the technology that allows us rapid intraoperative diagnosis within 2 to 3 minutes with artificial intelligence for decision support, as well, finally, as augmented reality presenting an accurate overlay of the patient-specific images within the surgeon's field of view, allowing the surgeon to maintain focus on the task at hand, to prevent cognitive switching, and ultimately lead to better outcomes. So the evolution of our field in neurosurgery has been over the course of about 130 years, from these line drawings where we had to guess where the tumor was, to MRIs based on cross-sectional images in black and white, to these three-dimensional 360 reconstructions which demonstrate all the available information and necessary information for the surgeon to execute the plan. And as we continue to evolve in 2019 to 2021, over the last 2 years, with the advent of heads-up display, augmented reality, integration to both endoscopic surgery and microscopic surgery, we really are leading the field in the ability to get to best possible outcomes, not just with pituitary surgery, but with all intracranial surgery as well. I thank you for your attention. I hope it's answered some questions about how do we put these technologies to work and how they can help patients. And I can take any questions you may have at this time.
Thank you, Dr. Lewis. That was a fascinating presentation. We did have one question and a follow-up question, and it is, are the AI images generated from the traditional MRI, or is there an AI-specific imaging machine?
I realized we got done a little early. I usually a lot of time for questions, and I'm happy to field those if you guys have anything. Also, it's pretty well known that 40, 45 minutes is usually the limit of people's attention span. So I try to deliver the message in that amount of time. So
Thank you. Can you hear me, Dr. Lewis?
are there any questions?
Can you hear me?
Yes, now I can hear you. Yes.
Okay, now you can hear me. Okay, we did have one question.
Sure.
Are the AI images generated from the traditional MRI, or is there a specific AI imaging machine?
So I assume they're talking about the artificial intelligence ones for the optic nerve. They're generated from the same MRIs that the patients have to prepare for surgery. So there's no specific MRI machine. They are done with what's called stealth protocol or thin cut protocol, which is the protocol that we use to get either 1 or 1.5 millimeter slice thickness, just in order to give us the resolution we need to get those images. But other than that, the images can be generated off of any thin cut MRI.
Okay, thank you. And that was our only question today. So that was an amazing presentation. We really appreciate it. Thank you, Dr. Lewis.
Thanks so much for having me.
And this will conclude today's webinar presentation. We appreciate you taking the time to join us. If you missed any part of this webinar, or if you would like to share it with family members or friends, it will be available on our website at www.pituitary.org after it is edited. And there will be a brief survey after the webinar. Please fill it out to help us provide you with the information you need today. Thank you for joining us, and enjoy the rest of your day.